Welcome back to the Moxie podcast, Full Potential. In our previous episode, we talked about why women don't have to settle for low libido and kind of the origin of low libido, the generalized conversation of women's sexual health. And today it's a solutions-driven conversation.
Ooh, I love that. Love me a solution.
Yeah. So how Moxie can help with those and what we offer here.
Okay.
The O-Shot, with or without hormone replacement.
So let's dig deeper and let's talk about what the O-Shot is. Alex?
Makes everybody so nervous.
I know.
When we talk about the solutions part, everyone's like, oh, great, let's have a conversation about this. And then what do we do about it? I'm like, I'd like to stick some PRP in your clitoris and your vagina. And they're like,
oh, I'm good. No, thank you. I'd rather not have sex. No.
Yeah, no, I just want to reframe it. Like the O-Shot, the first thing I want to talk about is what it is. So O stands for orgasm. Although it is used for sexual enhancement, there's a lot of other applications for it. Some women get it just to help with urinary incontinence because we are putting that PRP in the anterior vagina just under where the urethra and the bladder is. So it's very, very helpful with that. It helps with intensifying orgasms as we get older or just hormonal changes, even having kids. Reaching climax can be more challenging, and then climax can be more dulled as well. So from a sexual enhancement standpoint, that's great, but there's also a lot of great health implications like urinary incontinence, vaginal rejuvenation. What's another one we get a lot that we hear about?
Lubrication.
Lubrication. Yes. Thank you. That's actually one of the major ones. And then there's actually some really cool studies with the O-Shot and using PRP for lichen sclerosis, which in the GYN world of me, it's a tissue disorder essentially of the vulva. So there is some medical implications on how we can use it. At Moxie, we really do a lot of incontinence, lubrication, and sexual well-being. So we'll kind of focus on that.
So you said that you inject the PRP into the clitoral area. So kind of my whole understanding is I use PRP all the time. I draw the blood, spin it, get that plasma. PRP stands for platelet-rich plasma. And I inject it either under the eyes or in the hair. And what it does, it regenerates new tissue, new collagen. It firms up the area. Am I understanding then if you inject it down there, it's kind of going to do the same thing. It's going to regenerate new tissue.
Yep. It can help with nerve sensitivity, stimulation. We're helping the glands in the anterior portion of the vagina create lubrication and regenerate from that standpoint. That's why it's also very helpful with urinary incontinence. Sometimes it's just a volume too. We're putting in all of those platelets and all that plasma into the space between the urethra and the bladder. And that helps with incontinence while we're waiting for the regeneration process to happen. We're drawing people's blood. We're spinning it down in a centrifuge. We're isolating the plasma and all those copious amounts of platelets. And then we are strategically injecting it into tissue to regenerate cell growth, collagen. It's restorative, right? It's not necessarily meant to be enhancing. It's meant to be restorative. So when we put it under the eyes, it helps with crepiness. When we put it in the hair, it helps with hair growth. When orthopedics use it, they put it into joints, ankles, knees, so on and so forth. So there's a ton of medical applications for it. When we put it into targeted tissue, we're looking for a specific response. So with the O-Shot, we spin the blood down, separate the plasma. I'm going to put 1 cc, which might not mean a whole lot to people in medical lingo, 1 cc of that into the clitoris itself. And we numb it up. And then I'm putting 4 cc's of activated PRP into the anterior portion of the vagina. So it's really 2 pokes in 2 different areas that I'm targeting that tissue. Again, the top tissue is really for sexual enhancement exclusively. And then the bottom portion is for sexual enhancement, also the other added medical benefits like lubrication, response, variation.
And I think people kind of are probably already thinking, oh my gosh, she's stabbing my clitoris. What pain level wise? I mean, I can even speak on it. I had it done kind of, when we first started doing it. I'm like, sign me up. Let's try it. Honestly, I would rather get an O-Shot over
a pap smear.
A pap smear every day. All day, every day.
That's kind of the metric I use with women.
At all. Like, not bad at all.
That's the metric I use with women. It's more comfortable and less distressing than getting a pap smear. So we're not using a speculum. We're not doing any of that. I do carry a specific chair to use stirrups. If
I don't even know if we need to.
I've never needed to use them. Like, let's keep you as cozy.
Absolutely. It was very, very
nice warm blankie.
It was not a bad experience at all. I was a little freaking out because, I mean, nobody wants being stabbed down there, you know, but it was not bad at all.
Prospect doesn't sound enlightening.
And then, I mean, ideally, how soon after the treatment do women feel the results?
Back up. We will numb you.
No, yeah.
Topical
numbing.
I can do a lidocaine block too.
Yeah.
I used to lidocaine block everybody for the clitoral injections, and I found that the lidocaine actually burns a little bit more than. There's not as much net benefit to it. And if I just let the topical sit on longer, people are actually happier and there's better pain control. But I can do a block. If people are totally in their head about it, let's just block it out.
Yeah.
As far as when people experience efficacy, the fact that it's regenerative means that we're looking at about that 2 to 3 month period. I always give people conservative estimates. However, some people start to feel some awakening and some nerve growth and just generalized improvement around 3 weeks.
I was going to say mine was like 2 to 3 weeks and I felt the difference. Like definitely way more sensation, more heightened, more sensitive, you know, in that area. That's what I felt first. So yeah, that was like a couple weeks in.
Typically we can get away with doing 1. Every once in a while we'll have to do 2. Again, everybody's response to stimulation of their own collagen and regeneration is a spectrum of response, I guess is a better way to put it. So about 85% of people, when I do the O-Shot, 1 and done, and then it lasts for about 12 to 24 months.
That's not bad.
No.
Not at all. Like every 2 years, come in, get it done. Like not bad at all.
And some people may have, you know, it's individualized. So let's say it's for incontinence and people are like, I love the sexual benefits of it, but I'm really seeking control with incontinence. Perhaps it makes more sense to do 2 up front to really get tight optimization and then come in annually so you don't let the incontinence get worse again. And now we're rebuilding. We're keeping up with it.
I mean, question, can you do too many of these?
No. The safety
profile it's just PRP.
Exactly.
Essentially, it's your own plasma. It's your own vitamins that you're injecting into the body. So in my head, you can do as many as you want.
Totally. We don't want to have to subject people to having to do that if they don't have to. Not that it's horrifically uncomfortable. And we make people feel cozy as we can. But less is more. That's our general philosophy.
Less is more.
Less is more. But no, there's no safety or risk profile to doing too much. The only real documented complication of the O-Shot, because people do ask like risk benefit, it is a medical obligation to explain risk benefit ratio. The only documented risk factor was when a practitioner injected too far into the anterior portion of the vagina and actually got it into the urethral space. And it caused a temporary urinary obstruction that self-resolved on its own after a couple of days, but required like catheterization. And they couldn't void their bladder. You know, on
so
their
that's
own.
kind of risks that can
now
happen.
I will tell you,
every procedure has risks.
Yes, but I will tell you, with my background in obstetrics and gynecology, it's my hood.
Literally.
The women's space, the women's vagina, the women's genitalia, it's my hood, okay? I know where I'm going. I know what I'm doing. If
that I trust you. Yes. Yeah, you can do it blindfolded.
I used to deliver babies in the dark, and suture people up at 2 a.m. and repair things when I needed to. So we don't need to worry too much about that. I will get in, I will get out, I will get to the targeted tissue. I am not somebody who was in the med spa environment and wellness and now dabbles with women's genitalia. It actually was quite the opposite.
And honestly, I think that is, ideal. You're coming to a med spa, you know, kind of a woman's place, seeking all these answers. Who best to do a procedure than obviously somebody who delivered over, how many babies did you deliver?
Oh, like hundreds, maybe
thousands. This is your area. So you're really an expert in there.
We have the conversation within the med spa space. So I think a lot of people think that this is electively and luxurious and sexual optimization is meant for this space, but it really is meant to be functional and restorative.
Yes.
So it serves a purpose. There is a lot of great medical implication. There's great identity implication. So yes, functional and restorative, not luxurious in that capacity.
Yeah.
Okay. Does the O-Shot work for everybody?
Yes.
That's another common question. Again, I touched on it a little bit. 80 to 85% of people need a second one to get that full efficacy. We reevaluate at the 3-month period. But again, there's spectrum of response for everybody.
Everything,
So,
everything even we do comes to tox, fillers, everybody responds very differently.
Yeah.
And until you do it, then you won't know what the response is.
and that's for the personal relationship that we pride ourselves on having. Like the dialogue's
I
always
know,
open. The door's never closed. If it doesn't work for you, you're like, sorry, it didn't work for you. Like, come back. Let's talk about it. We'll figure it out.
We're not.
You are you. We are we. Like, we will figure this out.
I feel like we really thrive on that. Where like call us, text us. Like, we are here for you. Like, this is not
a common goal.
Yes, let's get you feeling the best possible. No, I love that.
We can use the O-Shot procedurally on its own. So ideally, it was designed in FDA. It's seeking FDA clearance. Coincidentally enough, there's something called a P-shot, which is, you can kind of think of what the equivalents would be in the penis. Yeah. And that is FDA approved, but the same equivalence for a woman is not, course. Right? So as we dabble into this, is a long tale as old as time, right? But as we're seeking it and as we get more indications for it, we know we can utilize it on its own. We know that it works best in peri and premenopausal aged women. Okay. But I do a lot of O-shots on menopausal and postmenopausal aged women, and they get immense benefit out of it as well. So even though the target age range for the O-Shot is like 30 to probably like 45, 50, that postmenopausal woman or that menopausal aged woman is going to get help with incontinence. I mean, my mom is comfortable. I did my mom, and she's almost 70 and, is madly in love with my dad again. And it's so beautiful. Oh my God,
I love them. I love them. They are sweet. Like teenagers. It's awesome.
And she's almost 70 and got enormous benefit out of it. And like, it's like, this is great.
I know.
So I will appropriately counsel people that this is the age range, but there's a huge spectrum of benefit for people even in that postmenopausal age range as well.
I'm sure, woman like my age, like, why would you get it? You're in your 30s, but like you have 3 children, hormones are changing, things are changing. And, it was very beneficial for myself too. So I agree with you. There's no like set, like you should be this age to get it. I feel like everybody could really benefit from it.
Yeah. You have 3 kids. Like, being optimized in your relationship and for yourself is only going to help
everything.
It's trickle down economics 101.
Now, kind of thinking back to, we've kind of talked in our last episode about, libido. We do a lot of hormone replacement. Would you feel then also, utilizing hormone replacement with O-Shot would be kind of the best scenario?
That's the creme de la creme. Okay. So we can utilize it on its own. As just kind of this restorative process. But when we also address any hormone imbalance at the same time, it is like, it's all coming together.
Yes.
And people feel their best. Mood regulation, right? We already talked about the complexity and multifactorial nature of libido and women's sexual health in general. And so again, if we approach it from that multifactorial standpoint, and we hit and solve a lot of different solutions, then outside O-Shot, restorative on the outside. HRT addresses the internal processes that are happening. And when we put it all together, it is, again, creme de la creme. It's amazing. Okay. The HRT component for someone in their 30s is going to look different for somebody in their 50s and beyond, right? In their 30s, that might be a little estrogen, a little testosterone, right? Yeah. Later on the line, maybe we're looking more at like adding in estrogen, DHEA. We obviously look at everybody's medical history and candidacy for all those hormones. Bioidentical hormones only is what we use here. So a lot of old research that did obstetrics and gynecology, and as us clinicians and as women, a huge disservice is the study came out that said HRT was dangerous.
Yeah, people come to me all the time like, well, can it cause breast cancer? And all these. And so they ask,
it created a 25-year narrative that they are harmful when we really have solid, copious amounts of data about how it's quite the opposite. But you do need to use bioidentical hormones. There's a huge discrepancy in that. Synthetic progesterone, for example, it proliferates breast tissue. So if somebody who has a family history of breast cancer, proliferating tissue is not necessarily ideal. Does it increase statistically your risk for breast cancer? I don't know, but it's creating this pathological process that we probably want to avoid. When you use bioidentical progesterone, it actually does the opposite. It is breast tissue protective.
How would you define bioidentical hormones? Like, what does that mean to somebody who's kind of like, okay, I'm not quite sure. What is that?
Basically, the molecule, the chemical is absolutely identical to what your body would make on its own.
So it's the
like
same
a
thing that you're
lock.
making already.
Yes,
You're
exactly.
just giving yourself more what you're missing.
And some of that is the route of administration. So oral estrogen, synthetic. Okay. So when we're using bioidentical estrogen, we're using the patch, we're using creams. So sometimes the modality of how we administer the hormones is limited because synthetic versus bioidentical, but we only use bioidentical because the safety profile is fabulous. I think one added benefit of HRT that people are really starting to talk about is that testosterone in men and women is one of our #1 dementia risk reduction strategies.
That's interesting.
Tons of cool literature and data coming out on that. So, I mean, we could talk about that for days. Give me the bottle of tequila. Like, we'll be here all night. But if we reel it back to the O-Shot and how we can use it in conjunction with that, again, we're just kind of bringing everything together. I'm trying to think of a specific example that we had recently. Did an O-Shot on a woman, had really good efficacy after one treatment. Right around that 2-month mark is when she had it. We started the HRT at the same time, little progesterone, little testosterone. And then as everything came together at about month 2, 2.5.
So it all kind of hit the same time. Fireworks.
Game changer.
Yeah.
And I get to hear about how it was a game changer for the relationship,
Yeah.
but more so than not, I would say women spend most time talking about how it was a game changer for themselves.
Yeah.
And their identity and how they
Absolutely.
how they
feel
move
like
through the world.
themselves again, you know, and I feel like that's the biggest thing. Women come to us like, whether it's aesthetics where they don't feel like themselves, sexually, they don't feel like themselves, maybe they've gained weight, you know, they don't feel like themselves. And so that's kind of, I feel like the common thread here. People come to us seeking, I just want to feel like myself again.
Yeah.
And just with whatever we do.
I want people to understand it's not risk-free painful. It's regenerative. We can do it with or without HRT, whatever you're comfortable with. And in order to promote people to have that conversation, I offer complimentary now. We've moved towards offering complimentary hormone baseline assessment
Blood
with
work.
labs, blood work.
Because you're already drawing the blood. So might as well get a couple more tubes, send it in. Let's see what's going on internally. Because then when it comes back and there are discrepancies, then you can address it. Yeah.
Yes. Ideally, I'd like to get a woman's blood work about a week before she gets her O-Shot, so we can sit down and make the most of her time and talk about the blood work in combination with the O-Shot. Maybe we talk about the blood work while the topical numbing is setting up. We make the most of everyone's time.
Absolutely.
And then we talk about how to strategize with that. But that's why we're offering that complimentary blood screening. It's just data points on you.
Yeah.
This is what's happening. This is how
Like,
we
why
find you're already here because you need a solution.
Yeah. So let's figure out what is exactly going on.
Right. And you don't have to obligate yourself to HRT. So say we get the blood work and we go over it and you're like, great to know. I'm not quite there yet.
Maybe down the line.
Yep.
But at least you know. At least, you kind of know what's going on in your body and you're aware of it. I think that's all we can do, just make somebody aware and then it's up to them.
What are some other questions? We had some people write in a little bit, a few things.
Somebody wrote in about the pain wise. We talked about that, how fast it kicks in. Oh, another one I remember. Is there any downtime with it?
No.
I mean, I can say you literally put on your pants and you go about your day. There's no downtime. So
you will find other providers that do the O-Shot who are like actually encourage you to go home and have intercourse that day because they feel like, or whatever, that they feel like it helps kind of kickstart the regeneration process. I'm a woman of science. I'm like, take it or leave it. It's going to do what it's gonna do. But no, there's no downtime. In the world of women's obstetrics and gynecology post-procedural, we always give people far more restrictive parameters post-miscarriage, post-DNC, post, uterine ablation, postpartum. We're worried about infection risks.
And
those
with
sorts
this,
of things.
there is none.
No, we're sticking a needle in. And so
a tiny little needle, like a Botox needle.
Yeah, but we're sterilizing everything. We're making sure everything's safe. So in theory, no, you can do your thing right away. No downtime. People even come in midday and they're like, I'm going to go to Costco after.
I mean, I'm going to go shopping. Hey, I just got my O-Shot. Let's go. Move on with my day.
That's it. Put your pants back on and
no, I love
check
it.
in with us.
I love mine. I no complaints there.
Yeah.
So.
It has definitely, in a kind of a comical relief way, been a great conversation topic for my girlfriends who have had it.
Yeah.
And they'll go like to like a wine night or go out with their other girlfriends or a girls trip, and they really talk about the added benefit of it. And then I feel like because that one person in the group has got it and had seen the benefits of it, now it's opening a broader conversation amongst women, which is great.
Yeah. And it's a very kind of unique procedure. I mean, I remember you were going through like testing, and you had to learn, and you took courses on it, you know, to be able to even do this
procedure.
Yes.
So that's another thing to say. Like, it is a patented, controlled procedure. There is an enormous amount of continuing education that is required as follow-up. You have to pass standardized testing for it. They even choose the candidate for it. They saw that my background is in women's health. They're like, you're in. You know, like,
But I feel like it's kind of like talking about it, like, be very careful where you go.
Yes.
I feel like not many people offer this, you know, procedure. And if they do, just making sure that they are qualified, accredited, you know, everything. Because it is, you know, gotta kind of know where you're going.
Make sure it's their hood.
Yeah, exactly.
Yeah.
And it's her hood.
Yeah. Awesome.
So,
what else have we heard that either that you had questions on before I did your O-Shot, or that you hear other patients ask about?
I feel like we hit on a lot of topics. I mean, like I said, ladies, don't be scared. I mean, book a consult. You can always call it, talk to Alex. It is not scary. If you're thinking about it, do it. I think it's definitely a game changer.
I think we should post a little video on maybe, or link pictures at some point to the room that we do it in. So you have some anticipatory guidance on where you're sitting. We put warm fuzzy blankets over you.
Yeah. I mean, if I get it done again, we can do a little video, like, you know what I mean? Not clearly privacy, but, you know, a little, I mean.
Your face is too pretty to look anywhere else.
No, but do not, if you're thinking about it, get it. That's all I have to say on that topic.
Love yourself.
Yeah.
Cool.
Well, that's a wrap. Until next time.